Hi, so in this video let's talk about diuretics, a topic under pharmacology. But before that, if you're watching this video, make sure that you like, make sure that you share, and please subscribe. Well, in order to lay some groundwork and to understand how diuretics work, it is better if we know what are diuretics. These are medications designed in flushing out extra fluids from the body tissues, and by doing that, what these medications do is that they increase urine output. And so to understand each class of diuretics, we're gonna need to go to our kidneys, and specifically the powerhouse of the kidneys, which are the nephrons, because each class of diuretics work at a specific point along the nephron, and by understanding the nephron and how it works, we shall have gone halfway in navigating through the journey of diuretics. So if you look at my board here, you'll see my diagram of the nephron, which I've drawn with different markers, and it is for the sake of better understanding of each class of diuretics. So first of all, let's label our diagram. So here, this is our Bowman's capsule. So molecules get through here, and there will be an increase in hydrostatic pressure, which pushes these molecules down to the kidney tubules. So this will be our proximal convoluted tubule, or the PCT, this being the descending limb of the loop of Henle, which is the DLOH. So this will be our loop of Henle, and this will be our ascending limb of the loop of Henle. So if you look at the descending limb and the ascending limb, they have one major difference, and it is an obvious one, because the ascending limb is wider, or it is thick compared to the descending limb. And so if this is the descending limb of the loop of Henle, this is going to be our thick ascending limb of the loop of Henle, TALOH. So this is going to be our distal convoluted tubule, DCT, and this is going to be our collecting duct, CD. With that, we kind of have a sneak peek of what we have here. And in the PCT, this is where most of the sodium will get reabsorbed back into the bloodstream. While at the loop of Henle, the descending and the ascending limb, this can be called something like the countercurrent exchanger. In other words, the fluids that are going down and the ones that are climbing up is kind of something, it's like people going down the escalator and they can exchange stuff. And so at the loop of Henle, that is where most of the sodium will get reabsorbed. Or rather, this is where the concentration of urine will happen. So with that, we kind of have what we were looking for, and we can go through each class of diuretics, looking at the physiology and how they play off the role of flushing out extra fluids from the body. So let's start with the osmotic diuretics. So osmotic diuretics, with the guide being the color of my marker here, is that they play their role at the area of the nephron called the PCT, or the proximal convoluted tubule, and also at the descending limb of the loop of Henle, DLOH, that way. And these medications, what they do is that they act as a magnet. And with that I mean, they pull up extra fluids from the body tissues, and they take these fluids back to the vascular space. And with that, they kind of pull a lot of water, which eventually will create something like a traffic jam at the proximal convoluted tubule and the descending limb, which eventually these fluids are gonna leave the body via the urine. Well, so these medications, apart from doing the job of diuresis, what else do they do? Is that they are used in cardiac surgery. So these medications are used in cardiac surgery, and their job is to reduce cardiac or edema, pulmonary edema. So apart from that, these medications, they are so good in what they do and they have another name. They are oxygen-free radical scavengers. What that means basically is that apart from reducing swelling, they also help in reducing or preventing cell damage. That is all that these medications do. So that is the physiology behind the osmotic diuretics. What is an example of these medications? Take a drug like mannitol. And mannitol is a large molecule, and once it passes through the Bowman's capsule and gets into the kidney tubules, what it does is that it pulls these extra fluids from the body, taking them into the vascular space, and eventually these fluids get lost through or via the urine. So we are done with osmotic diuretics. Let's now climb up to look at loop diuretics. So the loop diuretics work at the area of the nephron called the ascending limb of the loop of Henle, ALOH. And what these medications do is that they also used in preventing or treating heart failure, and this is acute heart failure. So how these medications work is that they inhibit or they block a pathway at the ascending limb of the loop of Henle, and this pathway is called the NAC-ACL co-transporter or the NAC-ACL symporter. So in order to understand how they play off their role, it will be better if we revisited the NAC-ACL symporter mechanism, and with that we kinda gonna understand how the physiology of loop diuretics happens. Well, it is worth noting that every co-transport mechanism is dependent upon the sodium-potassium ATP pump. So before getting into the NAC-ACL symporter, let's first look at the sodium-potassium ATP pump or the sodium-potassium ATPases. So what we know is that sodium is high outside the cell, right? And sodium is in low amounts inside the cell. At the same time, potassium is high inside the cell, and potassium is in low amounts outside the cell. So the sodium-potassium ATP pump is a primary active transport mechanism, and in primary active transport we are utilizing ATP indirectly to take materials from the region of low concentration to the region of high concentration, and because they are doing that against their concentration gradient, ATP is needed. So this sodium-potassium ATP pump have got special enzymes on them, and these special enzymes get called ATPases. And what these ATPases do, when they attach themselves in this ATP pump this way, so these are the ATPases, when they do that, they take a molecule of ATP and they convert that ATP into ADP, and this ADP, see what it does. So this ADP is responsible in changing this channel. It changes the shape of this channel this way. It allows sodium to move outside the cell from the region of low concentration to outside of the cell where it is highly concentrated. So what these channels do is that they change the shape this way. They change the shape, allowing 3 sodium molecules to leave the cell for every 2 potassium molecules that are allowed inside the cell. And so this is what these ADP molecules will do to this channel. And with that, what is created is a concentration gradient of sodium outside the cell. And that is where our sodium-potassium 2-chloride symporter come to play. So look, the primary or the secondary active transport mechanisms are dependent upon the sodium-potassium ATP pump. And the concentration gradient of sodium that was created here is what drives this sodium-potassium 2-chloride symporter to its place. So look, we have got sodium, and it is highly concentrated outside the cell, and we have got 2-chloride, which is highly concentrated outside the cell. And in secondary active transport, we say that we have got two molecules here. We have got molecule A and molecule B, and they are outside the cell. And these two molecules are trying to move where? Inside the cell. So this is inside of the cell. Molecule A will be sodium in this case. So, and molecule B will either be a molecule of potassium or glucose or even an amino acid. And so sodium, because of sodium-potassium ATP pump here, we have created a concentration gradient of sodium outside the cell. And so sodium can move inside the cell down the concentration gradient with ease and without needing any ATP. But for potassium, remember, it is less concentrated outside the cell. And so for it to go inside the cell, it will be doing that against its concentration gradient. In other words, potassium will be moving uphill from the region of low concentration to the region of high concentration. And with that, it will need an ATP energy for it to move inside the cell along molecule of sodium. So sodium moves in, it doesn't require any ATP, but potassium will take advantage of the molecule of sodium to also move inside the cell by utilizing the ATP that is found within sodium. It is easy as ABC. Let me give you one more example, and perhaps this will cement the understanding of the co-transport mechanism, and with that we'll go back to our loop diuretics and see how they play out their role of excreting excessive fluids from the body via the urine. So let's say we have got person A here and we have got person B, and what these two gentlemen are trying to do is that they are trying to have fun by swinging on a seesaw. So this is a seesaw here, and so person A is more weighty, so let me add the font here, and person B is less weighty, so, or he doesn't carry much weight. And so when these two gentlemen sit on the seesaw, because of the weight the person A carries, what will happen? Obviously the balance will tip towards which side? Person A's side, and person A will move down the concentration gradient, while person B will be carried up against his concentration gradient. So person A will be sodium and person B will be either a molecule of glucose or potassium. So look, sodium has moved down the concentration gradient because it is more concentrated outside the cell, and so it has moved down the concentration gradient from outside the cell to inside the cell with ease without needing any ATP. But for B, it has moved from the region of low concentration to the region of high concentration by utilizing the ATP that is found within A. And so A has carried B up the ladder or up the balance of this seesaw by giving him the ATP found in him because he doesn't need it. That is now the concept of the co-transport mechanism, and with that we kind of now understand how the loop diuretics work. So the loop diuretics, like I said, is that they block a certain pathway at the ascending limb of the loop of Henle, and that pathway gets called the NACACL symporter. In that, by blocking this pathway, sodium is now going to be reabsorbed back into the bloodstream, chloride is not going to be reabsorbed back into the bloodstream, and if sodium and chloride are not going to be reabsorbed, potassium as well is not going to be reabsorbed. And so what these three electrolytes will do is that they will create a traffic jam at the area of the nephron called the ascending limb of the loop of Henle, and eventually these electrolytes are going to be lost via the urine, because the idea of each class of diuretics is to flush out extra fluids from the body and excrete them through urine. Well, do you know the example of a loop diuretic? Yes. This drug is called furosemide, and the other name for furosemide is Lasix. And the reason it's called Lasix is because it is given at an interval of 6 hours. So this drug plays the role of blocking this pathway at the ascending limb of the loop of Henle, and this pathway is called an AKCl symporter. And by doing that, it disallows sodium to get reabsorbed, it disallows chloride from being reabsorbed, and with that potassium is not going to be reabsorbed, and these three electrolytes are going to be lost via the urine. And remember, where sodium and chloride are, water is pulled. Thiazide diuretics. So thiazide diuretics work at the area of the nephron called the distal convoluted tubule, the DCT. And what these medications do is that they allow the body to get rid of sodium plus water. But here is a fun fact. By allowing the body to lose sodium and water, these medications help the body to retain calcium. That is the interesting part of these thiazide diuretics. So they block a certain pathway at the distal convoluted tubule, and this pathway is called the sodium chloride symporter. By blocking this pathway, they prevent sodium from being reabsorbed back into the bloodstream, they prevent chloride from being reabsorbed back into the bloodstream, and with that sodium gets lost and it pulls with it what? Water. But with that it helps the body to retain calcium. So what is an example of thiazide diuretics? There is a drug, and this drug gets called hydrochlorothiazide, or HCTZ. So this drug is the one responsible in helping the body get rid of sodium and water, and helping the body at the same time to retain calcium. And this calcium is very essential. It is used to treat bone conditions like osteoporosis. Done. Now, carbonic anhydrase inhibitors. So these medications work at the area of the nephron called the proximal convoluted tubule. And what these medications do is that they block the actions of an enzyme called carbonic anhydrase. So this enzyme that I've drawn here is called carbonic anhydrase. So look what carbonic anhydrase does. So in the blood we have got CO2, and once this CO2 interacts with water, what does it make? It makes what we call carbonic acid. And this process is made possible by this enzyme we are calling carbonic anhydrase. The carbonic acid that we have created here further gets broken down into what we call bicarbonate plus hydrogen ions, and these are just protons. So look here, you've heard of a condition called altitude sickness, or in other words, a condition called acute mountain syndrome. And this specifically targets the mountain climbers or the hikers. We all know that by climbing up the mountain, oxygen levels start to reduce. Isn't that right? And by this, because there is high oxygen demand, what will happen, especially in the respiratory system, is that the body will start demanding for more oxygen while it is losing a lot of CO2 in something that we call hyperventilation. So, by losing a lot of carbon dioxide through rapid breathing, what happens is that carbon dioxide will reduce in the bloodstream, and that is a condition that we call alkalosis. So, by losing a lot of CO2 through hyperventilation or through this compensation mechanism of the body trying to retain or to stimulate breathing because of high oxygen demand, there is a condition, and this condition gets called respiratory alkalosis. When carbonic anhydrase inhibitors come in, they block the action of this carbonic anhydrase enzyme here, and so it means carbon dioxide plus water are now going to react to form carbonic acid, and this carbonic acid, remember that it's further get dissociated into bicarbonate and hydrogen ions. And so if bicarb is not going to be reabsorbed, more of bicarbonate is going to be lost through the urine, but hydrogen ions are going to be retained, and these are just protons. So what happens when your blood becomes too acidic? What do we call that? We call it acidosis. And so if carbonic anhydrase inhibitors are causing acidosis, what are they used to treat? So we can simply say that these medications are used in treating metabolic alkalosis. Done did it. So what is an example of these medications? An example of carbonic anhydrase inhibitors is this drug, and this drug is called acetazolamide. Potassium-Sparing Diuretics. You realize that in all classes of diuretics that we've talked about so far, there is lots and lots of potassium that gets lost through that process. But for potassium-sparing diuretics, they come in trying to spare the potassium that is getting lost. So for potassium-sparing diuretics, what they do is that at the area of the nephron called the collecting duct, is that they block the action of a hormone that we call aldosterone. Aldosterone is a very important hormone at the collecting duct in reabsorbing sodium, something that is very essential, especially in renin-angiotensin aldosterone system, in raising blood pressure and raising blood volume. And so potassium-sparing diuretics are going to inhibit the functions or the role played by this hormone called aldosterone, and by blocking its action, it means that sodium is not going to be reabsorbed, and so sodium is going to get lost. And once sodium gets lost, water at the same time is lost. But here is the kicker. By losing sodium and water, the body retains potassium that way. Well, what is an example of potassium-sparing diuretics? There is a drug, and this drug, we call it spironolactone. Spironolactone is what we call an aldosterone antagonist, because it is inhibiting the role played by this hormone aldosterone, and with that, aldosterone cannot reabsorb sodium, and so sodium gets lost through urine. There is another example under this class of diuretics, and that drug is called trimethylene. So for each class of diuretics and the benefits that these drugs bring, there are potential risks. So let's go ahead now to look at the risks associated by each class of diuretics. Well, so let's start with osmotic diuretics. We have seen that osmotic diuretics, there is high amount of fluids that get lost, and so one of those that get lost is water, and also there are electrolytes that get lost in the process. So one of the potential risks for these medications is electrolyte imbalances. That is one. And also there is higher risks of dehydration. That way, the loop diuretics, there is high risk of what we call hypokalemia, and that is excessive loss of potassium. There is high loss of sodium as well, so there are risk of hyponatremia. And with hyponatremia, there will be other risks such as headache, confusion, and even seizures, something that is not good. Well, still at loop diuretics, there is high risk of ototoxicity, and this happens in high dosage. So for thiazide diuretics, what we have observed is that the body is helped in losing sodium and water, but at the same time calcium is retained. So one of the risks is hypercalcemia. So hypercalcemia has other associated risks like kidney stones and hyperthyroidism. Other risks associated with thiazide diuretics are hyperlipidemia and also hyperglycemia, a risk especially with diabetic patients. So for carbonic anhydrase inhibitors, we saw that what these medications do is that they block the action of the enzyme carbonic anhydrase. And if there is no carbonic anhydrase, there won't be formation of carbonic acid, which later dissociates into bicarbonate plus protons or hydrogen ions. And so bicarb is going to get lost while the body retains protons. So when these protons get retained, what it means with high acidity in the blood, it means that the risks associated with carbonic anhydrase inhibitors is acidosis. Done. So for potassium-sparing diuretics, what these drugs do is that they block the action of the hormone aldosterone, and by blocking the action of aldosterone, sodium is not going to be reabsorbed. And once sodium is not reabsorbed, it will get retained in the kidneys, and it is going to get lost together with water. But the fun fact about these medications is that by losing water and sodium, potassium is spared. And so with that, we can say that one of the risks with these medications is hyperkalemia. And the risk with hyperkalemia is that there will be other risks like cardiac arrest, another risk like heart rhythms. Done. So you realize that diuretics do not work in a vacuum, and they are used as part of the big puzzle. And so that is to mean, whereas drugs like loop diuretics are very essential because of their fast action, there is too much loss of potassium in their action. And so combination therapy with other medications like potassium-sparing diuretics will be essential. And so let's go ahead and look what are these, or what do doctors consider when they are giving out these medications? One of the factors that doctors will consider when giving out these medications will be potassium levels. So doctors will also look at electrolyte imbalances, while at the same time looking at the patient's overall health. And again, doctors will also consider what we call fluid overload. And lastly, the doctors will consider the kidney's health. Kidney's health, and with that it can also mean any underlying condition. And that poses the question, if diuretics work along the kidney, does it mean that if the kidneys are not functioning well, that these medications are not going to function? That is right. And in that case, if the kidneys are not functioning properly, doctors will consider other medications like kidney dialysis. Well guys, that was all for today. We've looked at diuretics, we are doing diuresis. We've talked about each class of diuretics, starting from osmotic, loop diuretics, carbonic anhydrase, thiazide, and we finished off with potassium-sparing diuretics. We've also looked at the risk associated with each class of diuretics. And with that, I hope that this video was helpful. So like this video, please share, and of course please subscribe.